Greetings, everybody. Welcome back to PARM 2223, Unit 15. This is part 2 of our little foray into the future technologies and such of EMS. And if you recognize this picture here, you know that we're going to talk about some stuff that may or may not happen. I mean, who would have thought in 1980s that self-driving cars would become a reality, but we're there. So let's talk about things that people said would never happen in EMS, but are either happening now or hopefully will happen in the short-term future. Now, again, as we talk about these, remember we're talking, we need to consider where it is on the early adoption or the Rogers adoption curve, and also where it is when we consider the 4 dependencies or the 4 Ds of innovation. Okay, so now that I've gotten that out of the way, first and foremost on a lot of y'all's mind, I hope, if you are anywhere in tune with things, is POCUS, point of care ultrasound. Point of care ultrasound. And I remember we were talking about this in 2009, and we still haven't seen it adopted widespread, but every year more and more people are adopting this. The cost has come down. The dependencies are loosening up. Best practices are being developed, so on and so forth. So this is going to happen whether people want it to or not. Now, to give you a little background, when we talk about this, or to give you an idea to see if this is going to happen or not, every year more and more articles about the pre-hospital side of POCUS, granted largely from overseas, where they have bachelor degree trained paramedics with who are very self-directed, so on and so forth. But even in the United States, this is gaining a lot of traction. But when I was reading some of this stuff, it really surprised me that ultrasound has actually been around. Well, it's been theorized since the 1800s, 1876, but it's been around in clinical medicine since 1940. Think about it, 1940. And the tipping point, now it used to be predominantly just a rare radiology thing for obviously it's been common for a while in ultrasound and obstetrics, but even before then. But the tipping point has been really the democratization of this beyond radiology and beyond ultrasound techs into a much wider field. Ultrasound training is now standard in every emergency medicine program in the United States for emergency medicine physicians, as well as many other specialties, including family practice, because family practice docs many times are the obstetricians in their area. Since the 1980s, this was really kind of a push around cart, big huge cart, but now this technology, literally, I'm not exaggerating, clinical quality technology can be had on your cell phone with a connection called the Butterfly IQ. It's a ultrasound probe that connects via micro USB to a standard Apple phone. Just think about that. Think about when you talk about the early adoption curve, or the Rogers adoption curve, where this is, and when we talk about the 4 Ds, where this probably is. So this is really, really fascinating to me, and where it's going to go. I think that I may have probably 10 more years in this profession. I'm pretty sure we'll see this standard practice, or at least a best practice, adopted in the majority of ALS EMS agencies by the time I'm done and I hang up my spurs. You guys most assuredly probably will. So let's talk about what we use it for. At this time, you're probably thinking, okay, well, is it used for, you checking fetal heart tones, getting IVs, what are we doing? And the answer is yes, and so much more. So in the pre-hospital setting, this is what we're mainly seeing it. We're seeing it for fast exams, which are focus assessment in trauma. So basically, you're looking for free-floating blood in places it shouldn't be, in the chest, around the pericardium, and in the abdomen. It literally, when you do it right, takes 15 seconds or so to do a proper fast exam. There is now research and evidence and practice for pneumothorax detection. The big one that really excites me is you have that cardiac arrest patient, but you have a PEA, and you're wondering, is it EMD? In other words, the electricity's firing, but the heart's not responding. Or is it a low flow state in which case the muscle's responding just not enough that you can actually feel any sort of pulse. And those patients are possibly salvageable, with fluid resuscitation and vasopressors. We may see the return of central line placement with ultrasound. And in Ireland right now, last year, there was a study published on using ultrasound to detect and diagnose long bone fractures, and joint fractures and so on and so forth. Fascinating. In a rural environment, does this patient need to go in today? Do they have a hip fracture or whatever? Do they go in today, or can they wait to see their primary care doc? Imagine the utility of that, especially with longer transport times and limited resources. So here's the thing. It's not just... So the way the training tends to go is it's almost a la carte. So nobody is training paramedics to be ultrasound expert radiologist. But what they are teaching them is they're teaching them bits and pieces of that larger puzzle. They're teaching them the bits and pieces. And these mannequins exist right now today. I've put my hands on them at some conferences where we can teach people to identify cardiac standstill. We can teach people to identify pericardial tamponade, so on and so forth, in modules. So if you want to use your ultrasound in your system for 3 things, there are 3 modules plus the basic education. If you want to do 10 things, then there are 10 modules. There's lots of different ways this can be done, and done fairly well. So with that in mind, where do you think we are on this? Are we dependent? In the 1940s, we were. The technology was very expensive and specialized. The people with the education to use it correctly were very specialized. In the 1980s, we started to see it decoupling and spread into other limited basis into other fields. In the 1990s and 2000s, it's being widely distributed, best practices, mainly in emergency medicine. But now we're seeing it spread outside of that field, and we're seeing it innovated. We're seeing it miniaturized with the butterfly IQ. So we are past the early adopters, and we're in the decision to be, are we going to be in the early majority of this in most agencies? So, fascinating, huh? Something else, and I threw this in here, is 15 leads and beyond. We've been used to doing 12 leads so long that that's accepted. And when I started, the LifePak 10, I should put a picture up here. The LifePak 5 actually ran a code on one of those in my early days. And LifePak 10 had separate modules you could plug in to do 12 leads, but you had to print off each lead one at a time. So you had 12 different strips that you would play arts and crafts with and put it to a piece of paper for your diagnosis. And people said back then, and even when the LifePak 11 came out, which was the first integrated 12 lead, I don't need to know that. It will never change my care. And that was in 1995, 1998. Now, in Ada County, we got 12 leads in 99 or 2000, I believe, throughout the whole system. No, I take it back. We had them in 98 when I got here. We got the 12s, LifePak 12s, I think in 2003. But anyway, now people say, of course it'll change my care. I can diagnose axis deviation. I can differentiate VTAC from a bundle branch block. I can use it to activate the cath lab system. Lots of different reasons why this has a positive impact. So what's the next step? Better diagnosis. And the better diagnosis comes with 15 leads, so we can detect posterior MIs and or right-sided MIs. And these may even be expanded beyond that. And I can tell you right now in the next 2 years that there is a major manufacturer of medical monitor defibrillators that has 15 leads as an option, where you won't have to take off your right side precordial leads and try to get your left side or anything. That you'll put it on, and it will compare and detect them and run all 15 leads automatically. That's a fact. That's coming. So, where are we at on that? Because it's not in the field just yet. Well, we know that we're past the dependent stage, because this is no longer the realm of cardiologist and specialist. Paramedics do 15 leads now. But it's still kind of dependent on the technology. So it hasn't been distributed yet. It certainly hasn't been democratized. It hasn't been miniaturized. so on and so forth. So I think we're kind of in the process where right now it's decoupling. And I think once this major vendor that comes out with this in the next few years, probably 2 years, if not sooner, 18 months, you will see a tipping point where everybody will want to do it. So I think we're still in the innovators and early adopters. I think, well, I'd say early adopters because people are doing 15 leads in the field. They're just kind of patching it together with 12 leads. So, food for thought. Let's talk about dual sequential defibrillation, if you've heard this. Dual sequential defibrillation or double defibrillation, which is in essence for refractory VFib VTAC that persists despite getting shocked and despite medication. And your definition of this is really varied. Some people say 3 rounds, some people say refractory once, whatever. This was a thing that was gaining a lot of traction, a lot of interest. And in essence, you'd have 2 monitors or monitor and AED, and you'd try to shock along 2 different vectors at the same time. And this, last year when I gave this lecture, this was the hot topic, let me tell you. And there's the diagram. And what you see basically is you have, let me get my pen out, my laser pointer rather. You have 2 sets of electrodes, and this one is kind of misrepresentation. It should actually be on the back. I like this image better because this is more representative. And what you're doing is you're changing the direction of energy to hit different parts of the heart. Now, we've always done anterior, posterior, or apex sternum, but we're talking, this dual sequential defibrillation is about doing both. We know that the heart can take the energy without getting fried. The question is it effective? Does it reduce the overall period of cardiac arrest, and does it have a higher oscar rate? Well, early evidence showed yes. So we were looking at this moving from dependent, the realm of cardiologists. It was in the decoupling stage. Paramedics and systems were doing it, trying to establish best practices, but not doing it yet. So they were in this decoupling stage. There were no monitors that were rated for this. So one monitor manufacturer, Physio, actually came out and said you avoid the warranty. Zoll said you wouldn't, but they still weren't. It still wasn't FDA approved, so it was off-label. So we're really in this innovative portion right here, and maybe early adopters, but I'd say innovators here is where we'd be on this. So that was last year. However, just this, kept this in here because things change. This shows you how not everything pans out. And as you're a paramedic, as you go along, every 2 years or less, you'll see a new hot thing. 50% of the time, they become something better, and 50% of the time, they pan away. So this came out last year, in 2018, September, and has been reproduced several times. In that, I keep forgetting we're in 2020 now, that it didn't show a substantial improvement in terms of sequential defibrillation. It shows substantial improvement despite anecdotal evidence. So the thought process now is it's not the energy. The question they're exploring if it's the vector. So you don't really need a second defibrillator. You just need to change. You need to change the direction. So to put it in practical terms, what you may see is protocols where you simply apply a second pad, switch your defib over to your second pads, and shock that way for refractory. That's probably where I think it's going to go, but I don't know because we haven't seen subsequent research. So where is this? This is still pretty much stuck in the dependent, the area of specialty and decoupling, and we may see it just completely go a different path. Let's talk about what the hot thing is this year. The hot thing this year is heads-up CPR. Heads-up CPR. And basically what this is when you get a mechanical CPR device, pick your device. When you get a mechanical CPR device, whether it be the Autopulse or it be the Lucas, in our area we use the Lucas almost exclusively, but it's been done successfully, both. You raise their head up 30 degrees, and what you end up doing is the studies have shown that when you do it right, and key is I want to explain what doing it right means, so pay attention. When you do it right, there were providers noticing an increase in total CO2. So when I guess I should back up. What they were doing is they would sit people up, to go in elevators with mechanical CPR going, or some similar situation, and end-tidal CO2 would increase. Well, this happened enough times that somebody started questioning why. So with that in mind, they started exploring this, and they found that when you do it correctly, you actually improve hemodynamics because the abdominal mass and several other physiological features don't impede venous return. When you're supine, you actually have decreased venous return in some cases from increased abdominal mass and so on and so forth. So the idea is you can raise them up 30 degrees, improve ventilation, improve perfusion, which in turn increases ROSC, and you have better survival. And that's what we're looking for, and more importantly, better neurologically intact survival. Now the problem is, this is an interesting hypothesis, and they looked and they measured coronary perfusion pressure and cerebral perfusion pressure. And they found that, at 0 degrees, it's, whatever, and as they increase 10, 20, 30, and between 30 and 40 is where it kind of plateaus off, cerebral perfusion pressure does increase. And the reason is because it allows for venous drainage from the brain. And they describe this as interesting. One of the doctors who described this as every time we do CPR on somebody that's flat, we are in essence hammering the brain with a water hammer, but instead of a water hammer, it's blood hammer. It's almost giving them many concussions, and because of decreased venous return. And this may also be true partly because of hand positioning. And I didn't talk about this, but that's something that may pan out later, is they're looking at maybe hand position needs to adjust a little bit to the left because we also compress the aorta, and that may cause some problems. But anyway, that's neither here nor there. What we're looking at is by raising the head, you increase venous drainage from the brain, so you perfuse better, and you get better hemodynamics. So this is really interesting. This should improve neurological outcome. It should improve ROSC. It's a dramatic improvement. But this is what the original version of it looked like. I'm not sure how safe that is. I'm not sure how I feel about it. So where have they gone with this? Well, they've been doing research after research, and interestingly enough, and this is where it gets, I don't want to say sketchy, but this is where it gets interesting. Is this device. Now, the doctor who was doing the research and found investors and invested in developing this device. And if you remember the old CPR boards, this is very similar to that. And it's shown here with the Lucas plate, but there's a version of it also for the auto pulse. Now, here's the key, is that what they found is if you just raise their head up, you bottom out the pressure and you actually decrease survival. So a head has to be raised, and I don't know if they've actually explained the physiology behind this to my satisfaction yet, but it has to be raised over a 2 to 3 minute period. So you press this button and it slowly raises the head while mechanical CPR continues over a resuscitation cycle. So that appears to be the missing link that makes this successful. But also, the problem is that all the research has been done by the guy who's developing this product. So the other key to this is to see independent, verified, follow-up studies to see if other people are getting the same results. But it's interesting. This may be a thing in the future. So where are we at with this? Well, if we look at this slide again, I would say we're in the dependent stage. It's dependent on specialized technology, specialists doing the research on this. It hasn't been decoupled yet, hasn't been miniaturized, hasn't been, so on and so forth. But if it pans out, it's going to be on the verge. We're still in the innovative section. There are a few agencies that are trialing this, but they're not there yet. The other thing is that there are some confounding variables. So most of the studies with this have been done with a rescue pod, or when they've done it manually, they rescue QCPR, or not QCPR, this device, impedance threshold device and rescue pod, which if you want to do a study to prove something successful, you have to do it with very tight control groups against the standard practice. These are not standard practice. So the question is it the combination of all three of these devices plus the heads-up device? Or is it one, or is it the other? Is it something we don't know? So that's the other thing they have to figure out. And again, it has to be done independently by somebody other than is going to make money from this. Now, I say that sound like a cynic, but I think this has some promise. Now, here's something else. Speaking of mechanical CPR, mechanical CPR direct to cath lab. Now, most places will not take active CPR directly to the cath lab, and let's be honest, many patients are not a candidate. But if you have the witnessed arrest, who is in refractory PEA or VFib VTAC after a few rounds, or in a systole with good end-tidal CO2, but they're witnessed. Key is they're witnessed. They went down, and you have a history before they go down that implies a cardiac event. I have chest pain, I collapse, that type thing. These patients are prime candidates. Go directly to cath lab, have their coronary arteries opened up while mechanical CPR is going on, and get good recovery. Good recovery. This has been done. The problem is there's several barriers to this, and one of the big things when we see the transition from decoupling to distribution is cost. You have to have a positive financial incentive for this to become any intervention to really become widespread. And if not a financial incentive, at least not a financial barrier. In this case, there are some financial barriers to doing this because on the reimbursement side for cath labs, and a lot of physicians are reluctant, cardiologists are reluctant to do this because it skews their stats for their accreditation. And accreditation is strongly tied to reimbursement. So until that gets done, I'm not sure where that will go. I think we're past the dependent stage. We're in the early parts of decoupling, but I don't know if we'll move to distribution and best practices until the financial piece gets worked out. So we're still in the innovators and maybe one or two agencies, the early adopters. Now, this is another one that I'm really excited about. Actually, I'm going to stop right there because we're at 22 minutes. And we'll come back and we'll talk about Reboa.